Oh yeah, this one is another tricky one actually. The duration of response definition. Uh, uh, Actually, until I think recently, we didn't have such a big concern, about defining duration of response because actually we didn't have any approved drug. But now, because of the drug's approval, then although I think we are all taught to avoid comparing trials, but I think the physicians, the first thing they do is to compare trials. I know it shouldn't be done, but I can't prohibit myself from, uh, reading this. And I think the story about defining the response is about when we see in the registration trials of Ruxo or Belimozidil, it's about having like a fixed timeline, day 28 or week 24. And this is actually a little bit different from what we were used to when we report our retrospective studies, and non-controlled studies, where usually we report the best response in general. This is why I think we need to raise awareness about this, because you may hear someone saying, oh, well, response to Ruxo is this, and we published a paper with drugs XYZ, which was never approved, but it's the same. Actually, it may not be the same, because Ruxo was like day 28 and the other one was like, so I don't know what's the opinion of the panel about also highlighting these issues about the response, how to analyze the trials in an accurate fashion, I would say.
Well, I know duration of response is an endpoint that FDA now mandates for these trials to be reported on, but the definitions were changed across various trials, so sometimes it's hard to compare. So using the most current FDA definition of duration of response, which includes you have to first responded to be in that category, I think is critical.
Ali, you wanted to say something?
Yeah, yes. I mean, to be practical, probably it's as it was mentioned, the continuous response that matters actually in the setting of acute GvHD, because if you have a response that is only transient, then the interest of the drug is quite limited. I mean, it's the rate of sustained or continuous complete remission that matters most from a practical point of view, I would say.
I think one of the challenges came with in the acute GvHD trials, where the primary endpoint would be day 28 response, and then duration was from that day forward, versus in other trials, a patient may respond on day 7, and that's when the clock response interval and duration response was captured. That's one of the variables across studies.
But I think Ali is raising an important issue, which is, of course, you said, I mean, the durability of response, because obviously, when you look to the Ruxo trial, the refractory acute GvHD, you have one number at day 28, but at day 56, it decreased. Well, you're still doing better than the best available treatment, but I think this is something that should be highlighted. On the other hand, I think, while of course we appreciate that for regulatory purposes they need like a fixed timeline, but from a clinical standpoint, for me, if I'm treating a patient with Ruxo or whatever, belimozidil, etc., and the patient didn't have the best response at day 28 or week 24, but they have it at week 26 and day 35, I would say, who cares, as long as I have my response.
But I guess, Mohamad, it's a little different in acute GvHD because we all know, as Arnold has said, if we don't have a complete resolution, the patient still will have a poor outcome. That is different than in chronic GvHD. And we do have data in the pre-Ruxo era that, for example, that John Devine has published a couple of years ago, also from Andrea Bacigalupo's group, that response on day 14 correlates significantly with survival 9 months later. So I think, therefore, for acute GvHD, I would rather be in favor of earlier response assessment. So day 28 could already be fairly long. Of course, if a patient is progressing, you would change therapy before. But what I think clinically meaningful is also to not only have duration of response, but also survival. Because that's basically what ultimately is the most important thing for caretakers and patients, of course. And that would be at least at 6 months.
Yeah, and here you're bringing the issue of failure-free survival, in my opinion, because obviously we want them to be alive, but without disease relapse.
The reason why day 28 and John and I together worked on for the FDA the endpoints that could be used that correlated best with non-relapse mortality. There was more consistency with the day 28 in terms of predicting non-relapse mortality and survival at 6 months with the day 28. While day 28 seems like a long time, and while you're obviously know better than anyone that partial response in acute GvHD it may not be impactful. The reason why partial response came out important in the analysis of day 28 is because no one waits 28 days for a patient with lower GI GvHD to start a next line therapy if they have ongoing diarrhea, and those patients are a failure. Whereas a small percentage of patients who had a partial response in the skin, and those patients ended up doing well at longer time points and ultimately had achieved a complete response without further lines of treatment. So it's true, a partial response for lower GI GvHD at day 28 doesn't mean anything. That's not a win. But the reason why that as an endpoint was important was there was no patients, very few patients who were captured as a response at day 28 based on partial response for lower GI, because next line therapy was, of course, started much earlier.
Fantastic. Any other thoughts on this? People are tired. It's dinner time or lunch time, guys. I think Attilio, Dr. Olivieri, made also a nice comment. I can read it. Another important issue for response definition is also represented by the presence of irreversible damage in some organs, skin, lung, and salivary glands. And I think that's really important indeed, because once you have established scleroderma, and how you're going to assess this and so on. So Attilio, maybe you would like to comment on this?
Oh, it was related to the previous issue about the evaluation of response. That is sometimes it's very difficult to evaluate a response, to define a failure or a success when you face with an unchanged outcome in some organs, because, for example, particularly in patients with heavy lung involvement, it's very difficult to have an improvement of FEV1, for example, while in other organs you can observe an important improvement, such as partial response. So this is important in order to decide if continue the same treatment of to change, or maybe to add a different drug, maybe in order to have an improvement in such an organ, because we up to now we don't know which treatment is more indicated in some localization. For example, ACP is very effective in skin involvement, but we really don't know. We have so few data about the differential effectiveness of ruxolitinib in different organs.
Excellent. Can I ask you a question, Attilio? So if you have a patient today with a well-established, let's say, irreversible, you think lung localization, and you're testing a new treatment, and actually everything outside the lung has improved, what would be your conclusion?
So it's a very difficult question. So in a patient with the sclerotic sclerotic damage, often we can observe some improvement when before we thought that this was an irreversible change. In lung involvement, to my opinion, in my experience at least, it's very, very difficult to observe a reverse of a severe restrictive obstructive damage. So in these cases, I think the evaluation of trajectory of disease, so to my opinion, it's very important to evaluate in different time points the response, the variation of, for example, of measurable lung performance with FEV1. In some cases, the stabilization of a damage can be considered a success, for example. But this is there is another important aspect represented by flare, because it's very difficult sometimes to differentiate between flare of GvHD or microbial complication. To my opinion, this is very difficult aspect, because in some cases it's very hard to distinguish between the damage induced by microbial complication or GvHD flare, or both.
Yeah, very relevant, very valid point. And I think what's going to be even more challenging in the near future or the midterm, when we will have, for instance, in Europe, Bazarbachi available, and in addition to ruxolitinib, we're gonna have the issue of the sequence, and how should you use this or this before. In the beginning, I think we will have a lot of, let's say, Ruxo refractory patient, because if you just follow the numbers.
This is a good point. I completely agree. It's time to define a drug resistance, not generic refractories.
Yeah, so we'll have in the beginning a significant bunch of patients who will be Ruxo refractory or non-responding. They will go to belumosudil, but then rapidly we will have the patient, if assuming the labels are the same or roughly comparable, then it will depend on, I don't know which criteria. We have to dig a little bit deeper, I think.
It's an open field.
Yeah. But this is very exciting. I think we already had some good discussions. I don't know whether we missed something. We're almost at the end.